Today we will see about hypermagnesemia. These electrolyte disturbances are often very important in intensive care and emergency situations. So we must know about, in short, about these all electrolyte disturbances. Today we will see about hypermagnesemia. So what is the definition? A serum magnesium concentration of more than 3 milligram per deciliter is called as hypermagnesemia, and it is very uncommon in the presence of a normal renal function. So if kidneys are working properly, it is very uncommon to have hypermagnesemia. Then we'll move on to the etiology of hypermagnesemia. First is the renal causes. Chronic kidney disease is the most common cause. Then comes acute kidney injury. Then dialysis related errors. Second will be like excessive magnesium intake in the form of magnesium containing antacids or laxatives. IV magnesium therapy, which is used for preeclampsia, eclampsia, and bowel preparations. During bowel preparations, endocrine and other causes like hypothyroidism, adrenal insufficiency, and tumor lysis syndromes. These are some important causes of hypermagnesemia and even rhabdomyolysis. So, what are the clinical features of hypermagnesemia? So, it depends upon the serum magnesium level. If it is between 2.5 to 4, it will cause nausea, flushing, lethargy. If it is 4 to 6 milligram per deciliter, it will cause hypotension, bradycardia, and diminished deep tendon reflexes. So we generally check knee jerk whenever there is IV magnesium correction is given, and if the knee jerk is absent, it suggests magnesium increased magnesium levels, magnesium toxicity or hypermagnesium, and we stop magnesium uh, infusion. If it is 6 to 10, it will lead to muscle paralysis and respiratory depression, and more than 10, it can lead to complete heart block and cardiac arrest. So, how to diagnose? We have to obviously measure serum magnesium level. Then we have to look for renal function test in the form of urea creatinine. Then we can see for ECG changes like prolonged PR interval widened QRS and heart block. Management depends upon the severity and renal function. My hypermagnesemia is mild and asymptomatic. Then we have to stop any form of magnesium intake and hydration plus loop diuretics. If kidneys are working normal. Moderate to severe, there is moderate to severe hypermagnesemia, then IV calcium gluconate is given to antagonize the magnesium's cardiac effects, and IV fluids plus loop diuretics can be used, and last resort like hemodialysis, especially on patients with renal failure or if there is life-threatening toxicity. What is the clinical relevance? It is important in elderly patients with CKD and those using over-the-counter magnesium preparations to look for hypermagnesemia. It is often iatrogenic and it is preventable. Thank you.